Hi everyone, today we'll have a discussion about migraine and its surprising connection with these three conditions: autism spectrum disorder, attention deficit hyperactivity disorder, and obsessive compulsive disorder. Now, let me start by asking a question. How many migraine patients seem to have everything? The migraine patient who can't sit still and seems scattered, the person with autism who gets mysterious behavioral episodes that no one can explain, the individual with ADHD whose headaches never seem to respond to standard treatments. These may not be coincidences, but may actually be clues to fundamental connections in how our brain works. Now, this is brought to you by me and Neura Health, more in the description below. So let's start with an example. Let's meet Sophie. Imagine a 28-year-old marketing executive comes to the neurologist. Let's say you're the neurologist. She describes classic migraine symptoms: throbbing, one-sided headaches with nausea and light sensitivity. But as you talk, you notice she's fidgeting constantly, asking you to dim the lights, mentions she's always scattered at work, and admits she obsessively checks the weather forecast because storms trigger her headaches. Sophie represents millions of patients worldwide who don't just have migraine, they have migraine as part of a complex neurobiological picture that includes attention differences, sensory sensitivities, and anxiety patterns. Today, we'll explore why these connections exist and what they mean for patient care. Now, it's important to recognize that Sophie is not an outlier. Migraine rarely travels alone. Migraine affects 16 to 18% of adults globally, with 25% of women experiencing this condition. And as I said previously, we'll explore three key relationships with migraine: autism, ADHD, and OCD. Now, these seemingly separate conditions share genetic factors, brain pathways, and even treatment responses. So we'll discuss practical strategies that can transform how you recognize and treat these complex presentations. Let's begin with what may seem like the most surprising relationship: autism spectrum disorder and migraine. The connection has emerged from research, including genetic research, and has profound implications for both diagnosis and treatment. So here's a statistic that is rather startling. Autistic individuals experience migraine at rates of 35 to 42%, compared to only 10 to 15% in the general population. We're talking about nearly triple the prevalence here. Furthermore, a major meta-analysis published in Headache found 42.7% of autistic adults had migraine versus 20.5% of non-autistic adults. But this isn't just a statistical curiosity. For families dealing with autism, unexplained behavioral changes, increased agitation, or self-injurious behaviors might actually represent undiagnosed migraine pain. They could be migraine symptoms. When someone can't communicate properly that their head is pounding, they might show you through their actions instead. It makes you wonder how many of these quote-unquote behavioral issues are actually undiagnosed physical discomfort trying to find a voice. Even adults without autism spectrum disorder have difficulty communicating their migraine symptoms. So you can imagine how amplified this may be when autism spectrum disorder is present. And I'll leave you with this quote for this slide: sometimes what we label as behavioral challenge might actually be a neurological plea for help. So the genetic evidence is compelling. A 2025 study of over 337,000 participants found that individuals with higher genetic risk for autism were significantly more likely to experience migraine. For each standard deviation in autism genetic risk, there was a 4 to 5% increased odds of migraine. Also, those in the top 10% of autism genetic risk had a 12% higher migraine rate. Going the other direction, 35% of migraine patients showed significant autistic traits compared to only 17% of healthy controls. Now, at the molecular level, we won't go too into this, but both conditions share mutations in genes controlling neuronal channels: calcium voltage gated channel, sodium voltage gated channel, and the sodium potassium pump gene. These affect how brain cells communicate and process information. Now, the biology behind this connection is rather interesting and helps explain what families and patients experience. First, there's sensory processing overload. Between 82 and 97% of autistic individuals have atypical sensory processing. Simultaneously, migraine involves severe sensitivity to light, sound, and touch. Both conditions show altered connectivity in the thalamus. That's the brain's sensory gateway, the relay center, which normally filters incoming sensations. Think about it. If your brain's filtering system isn't working properly, ordinary sensory experience become overwhelming, potentially triggering both autism-related meltdowns and migraine attacks. Second, we have chemical imbalances. Both conditions involve problems with serotonin, the brain chemical that affects mood, pain, and sensory processing. They also show imbalances between excitation and inhibition in brain circuits, leading to hyperexcitability and sensory sensitivity. Third, the anxiety-sleep pain cycle. Anxiety affects 40 to 60% of autistic individuals and 30 to 50% of migraine patients. Sleep problems occur in 66 to 86% of autistic people. And sleep disruption is one of the most reliable migraine triggers and hints that migraine disease may be progressing. So these create vicious cycles where each problem makes the other worse. And I leave you with this quote for this slide. When your brain's volume control is broken, the world doesn't just sound louder, it triggers louder, throbs louder, and hurts louder too. Sensory overload in autism isn't just feeling uncomfortable, it's actually setting off migraine cascades. The anxiety that comes from constant sensory bombardment feeds right into the migraine pain cycle. So here's the challenge. Here's where it gets clinically vital. Traditional migraine diagnosis relies on patients describing their symptoms. For example, I have a throbbing headache with nausea. It's a clinical diagnosis that requires patient communication. But what if the patient can't communicate this way? So research for Boston Children's Hospital has identified behavioral signs that may indicate migraine in autistic individuals. Routine changes are often the first sign. Sudden loss of interest in favorite activities. So a child who typically spends hours building with Legos suddenly pushes them away and won't engage. Or an adult who religiously watches their favorite TV series every evening starts skipping episodes or turning off the show mid-episode. Or someone who loves drawing or painting suddenly stops creating art for days without explanation. So this all falls under sudden loss of interest in favorite activities. There may also be withdrawal from social situations. So an adult who regularly attends their weekly game night begins making excuses not to participate. Or a teenager who usually enjoys family dinners starts eating alone in their room. Furthermore, there may be changes in special interests. So someone who's obsessed with trains suddenly stops talking about locomotives or visiting train stations. Or even an individual who collects specific items such as coins, rocks, books, loses interest in organizing or acquiring new pieces. So any of these routine changes may actually indicate migraine in a person with autism. We also see sensory behaviors, increased covering of eyes or ears, seeking darker or quieter spaces, or showing distress with previously tolerable sensory input. Physical signs, head pressing against cool surfaces. This is found in 28% of autistic children with confirmed migraine. Increased repetitive movements or changes in eating and sleeping patterns. Emotional changes also occur. It could be unexplained irritability, meltdown without the typical triggers, or general deterioration in functioning. So for parents and healthcare workers, recognizing things like light sensitivity and irritability as migraine symptoms rather than just autism behaviors completely change the approach and may lead to effective treatment. And I leave you with this quote: pain doesn't always speak the language we expect to hear. Sometimes a child pressing their head against a cool wall is screaming louder than any words. We need to listen with our eyes and understand that behavior is communication. For these patients, it is vital to not rely on words, to not rely solely on speech. So assessment and treatment strategies. Assessment requires creativity and flexibility. We need to use visual pain scales or communication boards, involve caregivers as expert observers, track behavioral patterns over time, and consider multidisciplinary teams, including behavior analysts. Treatment focuses on environmental modifications, adjusting lighting, sound, creating sensory spaces. And because we have the right diagnosis, we can use migraine medications, which may be a game changer for these patients. Also, incorporating anxiety management adapted for autism, implementing sleep hygiene protocols, and provide family education about pain signals are all necessary. Now, using the FLAX scale is one example of this. It is considered one of the most effective pain assessment tools for individuals with autism who have communication challenges, covering both children and nonverbal adults. Although it was originally created for children, it has even shown effectiveness in intubated adults. Now let's look at ADHD and migraine, a relationship that has been confirmed by multiple large-scale studies and has important treatment implications. ADHD affects 5% of children and 2.5% of adults globally. That's 366 million adults worldwide. A comprehensive meta-analysis of 14 studies found that ADHD patients have 32% increased odds of having migraine. The relationship works both ways. The massive Danish blood donor study of over 26,000 healthy participants found that migraine was associated with ADHD symptoms with an odds ratio of 1.8. Meaning, if you have migraine, you're 80% more likely to have ADHD symptoms. So, what will you see clinically? In migraine patients, watch for ADHD symptoms. For inattention, listen to, "I can never finish what I start. My desk is always a mess," or "I forget appointments constantly." For hyperactivity, look for internal restlessness, fidgeting, or difficulty sitting still during an interview, for example. For impulsivity, notice quick decision-making without considering consequences, interrupting conversations, or emotional reactivity. In ADHD patients, screen for migraine. Incredibly important. So look for unilateral pulsating headaches lasting 4 to 72 hours, nausea, vomiting, or sensitivity to light and sound, worsening with physical activity, and at least 5 attacks meeting these criteria. Interestingly, migraine with aura shows even stronger association with ADHD, with an odds ratio of 2.05. And I leave you with this quote for this slide. The migraine patient who can never seem to finish what they started isn't being lazy. Their brain might be fighting 2 battles at once. That is ADHD and migraine. The shared biology, both conditions, ADHD and migraine, involve dysfunction in overlapping brain systems. The dopamine pathways are affected in both. ADHD involves low dopamine in frontal brain regions, which is why stimulant medications that increase dopamine are effective. Migraine also involves dopaminergic dysfunction, and many prodromal symptoms, like mood changes and food cravings, are also dopamine related. So it all comes together. Norepinephrine systems, they're also involved. This neurotransmitter affects both attention and brain processing. ADHD medications that block norepinephrine reuptake can improve attention, and some of these same medications work for migraine prevention as well. Both conditions show abnormalities in brain circuits, particularly the prefrontal cortex, cerebellum, and attention networks that significantly overlap. Now, here's a common clinical dilemma. Stimulant medications for ADHD can cause headaches in up to 20% of patients. How do you distinguish stimulant-related headaches from true migraine comorbidity? That is something you need to watch out for, whether you're a clinician or whether you're a patient. Stimulant-related headaches, they are typically mild in intensity, occur early in treatment, are related to dehydration or dose timing, and resolve with adjustments. True migraine comorbidity shows classic migraine features, like being unilateral, pulsating, or severe, have associated symptoms like nausea or photophobia, and can occur at any time, not just related to medication. For management strategies, start low and go slow with stimulants. Ensure adequate hydration. Consider timing relative to migraine patterns. If headaches persist, try non-stimulants like atomoxetine. And of course, use standard migraine treatments when appropriate. Now, the key to ADHD and migraine is addressing both of them simultaneously. Lifestyle factors like sleep schedules, regular meals, exercise, and stress management benefit both conditions. For medication selection, some drugs help both conditions like certain antidepressants. Environmental modifications may also help this patient population, including organized spaces and reduce sensory distractions. Behavioral strategies encompass time management, mindfulness, and coping skills. And I'll leave you with this quote for this slide. It has been observed that treating migraine results in an increase of efficacy in ADHD medications. It's all connected. Finally, let's examine OCD and migraine. Patients with migraine are 5 times more susceptible to OCD compared to the general population. In chronic migraine with medication adaptation headache, 25 to 36% of patients show significant OCD traits, with one study finding 36% positive on OCD screening questionnaires. Now let's look at this OCD and migraine cycle. It's listed here and it's available in chart format here. This relationship is especially important in chronic migraine and medication adaptation headache. So fear of migraine, we have anticipatory anxiety, okay? Worrying when the next migraine attack will occur. This anxiety triggers actual migraine attacks. Then you have more migraine attacks, and then you think, okay, well, that means my increased vigilance and medication use was justified. Sort of a self-fulfilling prophecy. And so, you take more medication, maybe even when you don't need it. This will lead to medication overuse adaptation headache, which will result in more frequent headaches because now you have incredibly sensitized your nervous system. The increased headaches will result in reinforced catastrophic beliefs. And then the cycle keeps repeating with escalating intensity. It worsens migraine, worsens OCD, and you have a patient in desperate need of care. The only way to stop this cycle from repeating itself is to treat OCD and migraine, but also OCD. You cannot forget to treat OCD if a patient is stuck in this cycle. And what's interesting and what makes this relationship so crucial is how medication overuse headache or medication adaptation headache, how these patterns mirror compulsive behavior. We see repetitive medication use despite diminishing returns. Now, for patients without OCD that have medication adaptation headache, this is because their migraine is not controlled. Their preventives are not optimized. This is a completely different scenario where a patient has obsessive compulsive disorder. So here's a clinical example of repetitive use despite diminishing returns. A patient going from 2 to 12 ibuprofen tablets daily, ibuprofen is an NSAID, over 6 months, chasing the relief she once got from lower doses. We also see anxiety-driven behaviors. So, for example, a patient taking pain medications preemptively without the neurologist's guidance when they feel even minor stress or sees weather changes. So a patient that thinks, I'd rather take it when I don't need it than risk being caught without it. Or a patient that refuses social invitations or work travel because they might get a migraine attack and can't get to medication quickly enough. So what if they have a migraine attack and they can't get to their medications? And this is a persistent thought that occurs in their head. We also see ritualistic behavior patterns around medication. So a patient that has elaborate pill counting rituals every morning, organizing medications by color, size, and expected potency. If they're not arranged correctly, I feel like they won't work. Or a patient that must take their triptan exactly the same time relative to symptom onset, using specific timing sequences, not based on guidelines. I have to wait exactly 15 minutes after the aura starts, then take the pill with exactly 8 ounces of cold water. Or even ones that store medications in multiple locations with backup systems, checking supplies obsessively. I count my pill 3 times every night and have emergency stashes in 7 different places. Now, I want to make a point here that there's obviously a difference between normal cautiousness and preparedness and OCD. That is for another lecture. Just know that sometimes it does overlap. And lastly, we have functional interference, disrupting daily activities. The patient that spends 2 to 3 hours daily researching new medications online, tracking symptoms, and managing medication schedules, missing work and social commitments due to this. And we also have functional interference disrupting daily activities, that is spending 2 to 3 hours daily researching medications online, tracking symptoms, managing schedules, missing work and social commitments. And I'll leave you with this quote for this slide. The line between reasonable preparation and compulsion isn't drawn by what you do, it's drawn by whether you can choose to not do it. This is to say that distinguishing between normal migraine management behaviors and OCD patterns relies on the loss of choice and flexibility. If no choice, then regardless of how logical the behavior might seem on the surface, it has become a ritual. So let's look at the neurobiological connections. Both conditions involve serotonin dysfunction. We see low serotonin in migraine and compromised serotonin function in OCD. There's also brain circuit overlap, as the same orbitofrontal striatal circuits involved in OCD also show dysfunction in medication adaptation headache. Both also involve stress response patterns and dysregulated stress systems. So what are the treatment implications? The presence of OCD traits predict poor treatment response to standard migraine therapies, higher relapse rates after medication withdrawal, more treatment failures, and earlier readmissions, and need for integrated approaches. And we will get to integrated care for this a bit later. And I'll leave you with a quote for this slide: "You can't successfully treat migraine without addressing the underlying compulsive patterns that contribute to it." So effective treatment requires addressing both conditions. SSRIs at appropriate doses for OCD, although SSRIs for migraine prevention are not usually effective for migraine. So you may want to choose a medication that is better for migraine and also treats OCD. Lastly, treatment for medication adaptation headache can't be done by following normal protocols, some of which include withdrawals. Underlying compulsive behaviors must be addressed for a chance at success. This is essential. OCD must be addressed while treating for migraine disease. Now, there are also behavioral interventions. CBT, cognitive behavioral therapy, with exposure and response prevention is important. This isn't the same as talk therapy, which might actually worsen OCD. Anxiety management are core components. Anxiety management is vital in battling this disease. And here is something very interesting and shows how all this is interconnected. Research shows that Botox treatment for chronic migraine also improves OCD symptoms, particularly checking behaviors and health-related obsessions. Very interesting, right? Now, let me walk you through what we're measuring here. So the OCIR is an 18-question tool that assesses obsessive-compulsive behaviors, things like excessive checking, washing, or organizing rituals, for instance. So this left graph A, shows the overall OCIR scores dropping from T0, that's before any Botox treatment, through T3, which is after 9 months and 3 rounds of injections. Now, this graph on the right focuses specifically on checking behaviors, patients compulsively verifying things like locked doors, if the stove is turned off or not, or repeatedly checking their medication supplies. The key finding: both measures significantly improved as patients received their scheduled Botox treatments every 3 months. This suggests Botox isn't just treating migraine pain, it's also reducing the obsessive-compulsive behaviors that often accompany chronic migraine, potentially by affecting shared brain pathways involved in both these conditions. Now that we understand these individual relationships, how do we approach patients who have multiple conditions? So, universal screening tools. Every migraine patient should be screened universally for autism traits using tools like the Autism Spectrum Quotient, ADHD symptoms using the Adult ADHD Self-Report Scale, OCD behaviors using the Obsessive-Compulsive Inventory Revised. The importance of routine screening protocols cannot be understated. The first step is diagnosis. Afterwards, collaboration across disciplines and think long-term management, not quick fixes. Now, it's also important to notice the red flags that we have mentioned in this lecture for complex presentations. For example, treatment-resistant migraine, unexplained behavioral changes, excessive medication use or checking behaviors, sensory sensitivities beyond typical migraine, and attention problems affecting daily functioning. We need to target shared pathways. SNRIs can help anxiety, OCD, and migraine, albeit not first line for OCD, but because a patient may have migraine, it may be a good idea to use rather than SSRIs. Environmental modifications benefit sensory issues in both autism and migraine. Sleep optimization helps all conditions, and stress management reduces triggers across conditions. So team-based care involves neurologists for migraine management, psychiatrists for medication optimization, psychologists for behavioral interventions, occupational therapists for sensory strategies, families and caregivers, if any, as essential partners. And the quote for this slide: the most effective treatment happens when every specialist sees the whole patient, not just their piece of the puzzle. Integrated care transforms outcomes by ensuring neurologists, psychiatrists, psychologists, and occupational therapists all understand the interconnected nature of these conditions rather than just treating them in isolation. So what's the practical implementation? The importance of routine screening protocols cannot be understated. Diagnosis is the first step. This can't be emphasized enough. Nothing else matters. And the only way to do this without missing a substantial number of patients is with routine screening protocols. If you are a healthcare worker watching this and you see migraine patients, make sure there are screening protocols in place. Having multiple conditions is common and treatable, but these patients must first be identified, advocate for comprehensive assessment, and build strong healthcare partnerships. Now, the field is rapidly evolving with exciting developments. Genetic research suggests that polygenic risk scores may eventually predict who's at risk for multiple conditions, allowing for early intervention. Precision medicine approaches using biomarkers and genetic testing may guide personalized treatment selection. Digital health through apps and monitoring devices can track symptoms across multiple conditions and guide treatment adjustments. New treatments are emerging as understanding shared pathways leads to treatments that address multiple conditions simultaneously. Again, the clinical imperative is clear. For those treating migraine patients, I strongly encourage systematic screening for autism traits, ADHD symptoms, and obsessive compulsive behaviors. You may discover that treatment-resistant patients actually have unrecognized comorbidities that, once addressed, dramatically improve outcomes. So by recognizing these interconnected conditions and treating them comprehensively, we can transform lives. Instead of patients bouncing between specialists being given incomplete care, integrated approaches can address their neurobiological complexity. The future is bright for migraine care. As our understanding grows, we're moving toward personalized medicine approaches that recognize each patient's unique pattern of neurobiological strength and vulnerabilities. The goal isn't just reducing headache frequency, it's optimizing brain function across every facet of life. Thank you for listening.